Dr. Baliga here. This podcast is a multiple choice question preparation for the boards from an outstanding chapter titled Perioperative Medicine in Baliga's textbook of internal medicine, available at mastermedfacts.com. The chapter is authored by Dr. Hugo Quinny Cheng, MD, who is professor of medicine at UCSF. He also completed his medical school and residency training there. He works as a hospitalist with a clinical focus on perioperative medicine. He also directs the Internal Medicine Board Certification and Recertification Review CME course for UCSF's Department of Medicine. A 78-year-old woman with mild dementia undergoes repair of a left hip fracture. On post-operative day 2, she is confused. On occasion, she states that the nurses and physicians are her high school teachers. At other times, she appears somnolent. Her vital signs are normal. Her neurologic examination shows disorientation to time and place, poor concentration, and impaired memory. What should be done next? A. CT scan of the brain. B. Review medications. C. Check thyroid stimulating hormone level. D. Start lorazepam. And E. Start risperidone. And the answer is B. Review medications. The patient presents with typical findings of postoperative delirium, which is very common after hip fracture surgery. Medication side effects often contribute to delirium, and medications should be reviewed. In the absence of specific findings to suggest a structural brain lesion, imaging is not needed. Thyroid disease is also unlikely to cause acute delirium. If necessary, for patient or provider safety, sedation with a neuroleptic such as risperidone is preferred over the use of a benzodiazepine such as lorazepam. In this case, however, the patient has not manifested behavior that warrants sedation. Postoperative delirium. The incidence of postoperative delirium ranges from 9% in a study of unselected patients undergoing major surgery to greater than 50% among patients undergoing hip fracture repair or cardiac surgery. Major preoperative risk factors include advanced age, cognitive or functional impairment, substance abuse, and prior history of postoperative delirium. It's uncommon to identify a single clear etiology for most cases of postoperative delirium. Infections and fluid electrolyte disorders sometimes play a role. Thus, it's reasonable to check a complete blood count, serum electrolytes, and urine analysis in delirious surgical patients. Adverse effects of medications, especially anticholinergics, opiates, sedatives, and muscle relaxants, are often implicated, so a careful review of medications is also indicated. In the absence of focal neurologic symptoms or signs, brain imaging has low yield. Similarly, there is little utility to laboratory testing for chronic metabolic disorders that can lead to cognitive impairment, such as vitamin deficiencies or thyroid disease. For patients at risk of harming themselves or others due to delirium, neuroleptic medications such as haloperidol are generally preferred over benzodiazepines or other sedatives. Most cases of postoperative delirium resolve within a few days, but recovery is substantially prolonged in some patients. This short case scenario is from an outstanding chapter titled Perioperative Medicine in Baliga's textbook of internal medicine, available at mastermedfacts.com. The chapter is authored by Dr. Hugo Quinny Cheng, MD, who is professor of medicine at the University of California, San Francisco, where he also completed his medical school and residency training. He works as a hospitalist with a clinical focus on perioperative medicine. He directs the medical consultation service and co-management with neurosurgery service, and regularly teaches about preoperative medical evaluation, perioperative medicine to residents and practicing physicians. He also directs the Internal Medicine Board Certification and Recertification Review CME course for UCSF's Department of Medicine.